Hello everybody, welcome to WVCTSI Symposium for this month. I'm glad to have you here, and I want to introduce our speaker of the day, Dr. John Hickner, an old colleague of mine, and I won't say how long I've known him so that neither of us will be embarrassed. He is the chair of family medicine at the University of Illinois in Chicago. He received his MD degree at Indiana University, and he did his family medicine residency at the Medical University of South Carolina. He also has a degree in clinical research design and biostatistics from the University of Michigan School of Public Health. He has had a distinguished career both as a practicing family physician, as a researcher, as the leader of 3 or 4 or 5 practice-based research networks that he started, including the National Practice-Based Research Network in Family Medicine, and comes here today to talk about how to improve primary care using practice-based research. So, welcome, John. Thank you.
Thanks, Dana. I have a couple of ties with West Virginia. The first is that a good colleague of mine, Henry Berry, practiced at Cabin Creek for 5 years. And Henry used to tell me lots of stories about what it was like, and he'd show me pictures of his practice in Cabin Creek, so I feel like I know a little bit about practice in rural West Virginia. And the other tie is not nearly so tight, and that is that I'm a great John Denver fan, so I'm not sure he has any ties to West Virginia, but we all think that he does because of his music. Well, let me go through these slides here. I prepared about 100 slides and scratched my head and thought, that's too many. So I cut a big section out, but I added a few more in. And then I was thinking, well, if MTV can go through 40 or 50 slides in a minute, I can certainly do 70 slides in 40 minutes. So there are a lot of slides, but I hope it'll be content that'll be useful to you. This is what I hope to cover. You can read as well as I can, but I think there's some people not here who can't see the slides. Is that correct? So I should probably say it. It's a short history of U.S. healthcare, a very short history of the NIH. Then we'll get into PBRNs, which is what I'm here to talk about, Primary Care PBRNs 101, and what I believe is a very significant role these practice-based networks can play in healthcare transformation. But my real objective or goal, you might say, is to make the case that primary care practice-based research networks are a powerful tool for healthcare improvement and transformation. This is the theme song. I think many of you are familiar with this song, especially those like Arnie that have a little bit of gray hair. Now, okay, who wrote it? All right, who said Dylan? A youngster even knew it. Very good. Yeah, you know, this sounds like our times right now, doesn't it? But Bob Dylan wrote this song in 1964. So we're still in the midst of huge social transformation, and especially in the midst of transformation of the healthcare system. So let's dig in. Okay, this is my really short history, or it's a short history of U.S. healthcare. Now, in the 1980s, the 1800s, there really was no formal system of healthcare per se. It was very much a cottage private industry. There was very little in terms of structure that held a healthcare system of any sort together. There wasn't insurance, there wasn't anything. So people sought healthcare from all kinds of proprietary medicine men of various ilks of training. In the early 1900s, though, hospitals became the center of healthcare, but physicians were largely still in independent practice. But by the 1950s, 60s, and 70s, some of these larger systems like Mayo Clinic and the Kaisers and others around the country were beginning to emerge. And of course, with the establishment of Medicare and Medicaid in 1965, that was a really pivotal event where government in a big way got it involved in our healthcare system, which it had not been pretty much at all prior to that time, except perhaps a bit on a state basis with public health. The late 1900s saw what I call the industrialization of medicine. That's when the Blue Cross Blue Shields, which were not-for-profit corporations around the country, began to break up and were allowed to become for-profit entities. And then we saw the investors swoop into the healthcare market, which different people can have different perspectives on how that happened, but there's no question that the result was that healthcare got aggregated into larger systems. Think of the Hospital Corporation of America as one of the largest. And it's also true that a lot of the resources that were going into healthcare were being drained out into investors' pockets, because this became a place for profit making. So it really did become a for-profit industry, although only partial, obviously. Many of us are still at not-for-profits. Even places like Mayo and Cleveland Clinic are still not-for-profits, but this is a reality of U.S. healthcare right now. Then something happened in 2000, and I call it the awakening. And what that was the publication of this book, this report, called To Err is Human, Building a Safer Health System, followed shortly after by Crossing the Quality Chasm. And I don't think I need to say anything more about it because I suspect you're all familiar with what happened. But this really was the beginning, just the beginning of a revolution in healthcare, where people started to say, enough is enough. We're spending so much money, we're not getting the value out of the healthcare system that we ought to. And this was driven primarily by private industry and employers saying, enough is enough. We really need to get much better value out of all that money we're spending on the healthcare system. Then for the next 10 years, there's some things happening, some developments, some trials to improve quality and safety. But then the big kahuna was the 2010 Patient Protection and Accountable Care Act, now called Obamacare, which of course we're all dealing with since then, and that's changed the ball game even more, although we're just kind of getting started into that. So that's our current reality. We're dealing with the post-Obamacare reality, and of course the constraints of the budget and all. I had a whole set of slides in here about the social context of healthcare in the United States, but I thought it would take too much time to go through all of those. But recall that this short history of healthcare in the United States is taking place against the background of huge social changes that are taking place that are typified perhaps by the internet and information technology as the background, and also the constrained economy that we're all dealing with right now. So that's all I'll say about the social context. Well, with the Accountable Care Act came the ideas of Don Berwick, who was secretively brought into the position in CMS as the director until he got kicked out by the Senate, basically. But he did have an effect in those 2 years that he was in the system, and he and others developed this concept of the triple aim of trying to really achieve improvements in population health and simultaneously improving the experience of health care or medical care, however you want to define it, and simultaneously reducing the per capita cost. And he and many of us believe that this is possible. And that's the era that we're in right now. The challenge is how to accomplish all of these things in a time of constrained resources. I believe that to achieve this triple aim is going to require not only social action, but it also is going to require research. And I believe it will continue to require traditional clinical research, as we all know it, but it also will require more what I might call quality improvement research, which has been bundled with the concept of health services research. But now we're speaking more specifically not about just describing phenomenon, which is health service research is mainly done, but actually doing something about it. by improving quality, and you all actually are quite engaged. It's fascinating to find a place where the unit called Health Services Research is actually doing quality improvement work, and that's really quite a novel concept. I'm not sure that I've seen that anywhere else in the country. Maybe it's happening and maybe I just don't know about it. But that's a very interesting resource that you have. And then finally, what's now being labeled as outcomes research, which is kind of a funny name. You know, it's a made-up idea that simply says we need to study what the important outcomes for patients are. And one way that we can achieve this is by not only doing clinical trials, but if we have the ability to do descriptive research by aggregating large amounts of clinical data, maybe we can figure some things out without subjecting everything to a clinical trial. So it's just kind of a new way of looking at different research methods that we've all used for years and putting a new name on it. And that kind of allowed CMS to get into the act. And they developed, as part of the Affordable Care Act, this place called the CMMI, which was given $500 million initially to do some action-oriented quality improvement, and yet they still call it research. So it's a very interesting entity. It's an experimental entity that a lot of us have some high hopes for, doing some action-oriented research to improve healthcare. So this is the background, I guess, that we find ourselves at, and this is the context in part that the practice-based research network movement find itself in right now. And we'll get to PBRNs eventually, but let's go through the NIH quickly, because I think the history of the NIH also has a large impact on our ability to fit into the total research enterprise. 1887, the Laboratory of Hygiene was started in New York City, and it was started because of concerns about illnesses that seamen were bringing into the country. That was morphed into the first Center for Disease Control type entity, and hence its focus on infectious disease initially. I just stuck Flexner in there intentionally because remember that prior to Flexner, medical schools were very proprietary, and it was Flexner's idea that we need to have a solid scientific basis for medical practice. And that Flexnerian movement was to bring medical schools into university settings so that all the doctors would have some basic training in science behind their practice. And that was necessary, I think, to think of the establishment of the NIH, because that then gave rise to the idea that medicine ought to be practiced on the basis of science, and maybe the federal government should get into the act in terms of studying the science that undergirded healthcare. So that's how NIH got started. The first one was NCI, established in 1937, and then most of the other institutes were established between then and the 1970s. Now, 2002 is an important date because that's when Zirhouni developed this idea of the NIH Roadmap, which led to the CTSA program. The purpose was to try to accelerate the translation of basic lab research into important findings that could affect practice. And at least as far as I can tell, he kind of invented this concept of translational research, although I don't know who first used the term, but this whole idea that we move from T1 to T2 to T3 type of research, and there are many different renditions of this particular diagram, some of which the NIH has published, and this one was done by a friend of mine. And I thought it was a nice formulation of the translational research ideas, starting at the top in yellow, going from cells to diseases to people and then to actual practices. And some people put another T out there now for the community, so that becomes T4. And then you can see in the research we have basic, then human, then practice-based research and quality improvement. That's the T equals QI into practice. This idea of implementation science is gaining a lot of traction these days, even at the NIH, where they're interested in determining, well, just how do we get this stuff done? How do we implement all these findings in practice? And down at the bottom in red, you can see that the indications are not ready for humans, not ready for patients, and not ready for practice, although that should maybe be a little bit farther to the left. But at any rate, it was Zirhouni and his leadership at the NIH that got this whole idea started, and hence we have the CTSA structure that you're participating in at this point. So I think that was a very important development to get NIH off the mark and trying to get the idea that they have some responsibility for actually getting things into practice. It was quite a novel idea back then. And then the other thing, let's see, which led to 2006, the Centers for Translational Science again. But the other thing that happened was the Center for Biomedical Computing was developed. And why do I put that there? I put that because of this, because of the Human Genome Project. It only became possible technically to have such huge data sets of biological data available because of supercomputers. So it wasn't until the era of supercomputers, supercomputers, that this work could even be done. And so it's really just since then, since about 2006, only a few years after the genome was mapped, that we finally have the infrastructure and the capability for what people are now calling personalized medicine. And how that's really being used, of course, is use of genomics and proteomics to influence and personalize healthcare. Those of us in primary care thought we were delivering personalized healthcare 30 years ago, and we still do think that's the case. But I think those trends will eventually merge and come together. So these, again, I think are the important developments on the national scene that influence what you're doing as you develop a practice-based research network. So let's start talking about these entities, which have come in the United States to be called PBRNs. So I'll go a little bit over definition, history of development of these practice-based networks, and by that I'm talking about primary care practice-based research networks, because there are many others. There's actually a retinal pathology research network as well, which looks a lot like a practice-based research network. The structure of successful PBRNs, the scientific rationale for the importance of these primary care networks, some examples of studies that they've done, and how PBRNs can be used to bridge that second to third translational gap. So here we go. Here's the official definition from a government agency, the Agency for Healthcare Research and Quality, which has supported PBRNs, a group of ambulatory practices devoted principally to the primary care of patients, affiliated with each other, and often, almost always, with an academic or professional organization in order to investigate questions related to community-based practice. Now, I like these next definitions a little bit better. Laboratories for healthcare reform. Interesting. The most important part of this slide is the date. 1994. 1994, 20 years ago, people were talking about these as laboratories for healthcare reform. So it's not as if healthcare reform is a new idea at all. These ideas have been percolating for a long time, and it's really only now, I think because employers have been hollering and screaming about the costs and poor outcomes, that we're finally getting there. But it was a long time ago that many of us recognized the need for reform. I like this one too, published at the same time, Reuniting Practice and Research Around the Problems Most of the People Have Most of the Time. A lot of NIH-style research has been pretty esoteric and may or may not apply to large groups of patients, but this is really getting it all together at the user's end, so to speak. This is a network's definition of themselves, and I think this is interesting. We're a practice-based learning and research organization designed to improve healthcare in its member practices and elsewhere in the United States. So this is a very action-oriented definition that I kind of like. It's about improving healthcare, and it's a learning organization, a learning and research organization. The Practice Partners Research Network has been around for about 10 years, and it's built on the infrastructure of 15 years of the EMR. It's run out of Medical University of South Carolina, and they have done some really nifty trials in cardiovascular areas, prevention, medication management, all based out of this network. So I like that definition. That's really what they try to do. This is more of a personal definition. This definition comes from one of the doctors that I recruited from a town of 5,000 in a small town in the Upper Peninsula of Michigan, who got quite enthusiastic. Her whole office loved to participate, and they would ask her, well, when's the next study coming by? And they would take the results of the studies and they would post them up on their bulletin board out in the waiting room. It's not being isolated in one's practice, but rather working together and being involved in advancing primary care in an interesting way. It's avoiding burnout while expanding our horizons and helping patients. Now, this is a doctor who was seeing almost 30 patients a day. She did hospital medicine. She had nursing home patients. And doing this extra work, you would think would cause more burnout. And she's saying, no, it wasn't that way. It really energized us and helped us avoid burnout. So there's your challenge as you build your PBRN. Can you build it in a way that the doctors will say this? I hope so. Just a reminder about some of the pioneers that even before we started doing research in networks, that there were some GPs out there who did some nifty stuff. McKinsey is the guy who discovered atrial fibrillation. Family doc. Will Pickles discovered the epidemiology of hepatitis A. A neat book called Will Pickles of Wensleydale is a nice chronicle of his life and his work in central UK. John Fry studied his practice in detail, kept detailed notes. Francis Huygens in the Netherlands studied families and interactions of disease in families and published a nice book about his work. And Curtis Hames is our godfather of practice-based research in the United States, who kept blood samples of serum on about 5,000 of his patients for the first 10 years in practice and put them in a freezer down in the basement of his office. And then he went and knocked on the door of the School of Public Health at University of North Carolina, and with his southern gentlemanly drawls told him about this data. And then he was funded through NIH funding for 25 years, working in conjunction with the School of Public Health at University of North Carolina. Just marvelous work. I think the original isolation of hepatitis B virus was out of one of his vials from his patients. And what else? Something about lipid profiles. Some of the original work on lipids were done off of his samples from his office. So there are some pioneers out there that serve to inspire us as family doctors and generalist physicians. The idea of networks is not new either. This is just a few dates about when these various networks were formed. The first real, not official PBRN, but it was the GP Birth Control Pill Collaborative in the UK in the 1950s, in which many of the GPs contributed data about morbidity and mortality from birth control pills when they were first developed, because it really wasn't known how many women would have serious side effects. So the safety data on birth control pills was done by a network of GPs in the UK in the 1950s. But the Dutch Sentinel Stations was the first formal network that got together. And these are just some others. I simply want to illustrate that there are a whole bunch of them out there. Here's more of them. Most are family medicine, but not all. Some are pediatrics, some are general internal medicine, some are nursing networks. And this map is a few years old, but this gives you an idea about some where some of these networks are located. I see a blue spot in West Virginia, at least in this map. So there's one for West Virginia down, okay. They're in other countries too. It's really an international movement. They're all over the world right now. In the 1980s, we had about 26, and they were beginning to produce some interesting information that I'll come back to. In the 90s, there were over 50 of them, and this is when AHRQ got involved and started to support development. And we're beginning to see some of these networks get some funding from the other NIH agencies. But it was really in 2003, remember, that was about the time of the roadmap, that these PBRNs got discovered in a big way, because people were thinking about how do we get research out into the community, and practice-based research networks were an obvious way to do it. So Sung published this article in JAMA that he called Central Challenges Facing the National Research Enterprise. It's the first time, I think, that a journal of the stature of JAMA explicitly included the term practice-based research networks. So I think this was the first time in 2003 that we were really discovered, even though they've been around for a long time. And now ARC is still supporting in a small way practice-based research networks. This is a slide I just took off of their website that has some statistics on it. Now there are at least 136 that are registered, and we know there are more than that. Most of these are primary care, not all primary care, and serving a population of 48 million. So that includes about 15% of the population of the U.S. are involved in practices. Let's see. Let me just tick through these quickly, and these are some of the areas of research interest. 70% have used EMRs for research. Okay, that's a little bit of the statistics. Now, why should we have these? How are we doing with time? Pretty good. I'll talk for about 10 or 15 more minutes. You know, I got interested because of tympanostomy tubes. I'm not a researcher. I'm still not a researcher. I mean, I'm an organizer of research maybe, and yes, I have some research training, but I didn't do any research in undergraduate. I did no research in medical school. I only started to get involved in research when I got out into practice and found out that I didn't know enough to really practice, and nobody was doing the kind of research that I needed or wanted, except maybe Jack Paradise at Pittsburgh. Two of my kids had tympanostomy tubes because of recurrent otitis media in residency, and so I gave a grand rounds on tympanostomy tubes, and when I did the literature review, I was shocked to find out that there were no randomized trials of tympanostomy tubes, that they were just being put in left and right because it seemed to be a good thing to do. And so that really got me interested. I'm thinking, okay, did my kids really need tympanostomy tubes? Well, Jack figured that out, but not till 25 years after my kids had their tympanostomy tubes, and the data, of course, doesn't support tympanostomy tubes except for extreme cases. So that got me fired up, I guess. And then I started complaining to Jim DeLynn, an older doctor in town. I practiced in a small town for the first 22 years, a town of 14,000. And I was complaining to Jim about how I would send patients off to medical centers for their various problems, and they seemed to come back, and I was not being able to figure out how to manage all these patients' problems. And then he pointed out to me that I was trained in a medical center down at Medical University of South Carolina, and that most research was done in medical centers. So he said, well, why did you expect that you would be able to manage all of these problems when these patients haven't even been studied yet? And I said, oh, okay. Well, that makes sense. And of course, it actually was studied by, at least the distribution of healthcare was studied by Carr White back in 1961. How many have seen this particular classic? Well, that's good. So most of you haven't seen this. Well, this is about distribution of healthcare seeking in the United States that Carr White, sort of a godfather of primary care research at Johns Hopkins and mentor of Barbara Starfield, cobbled together back in 1971. The time frame is 1 month. So in a given month, believe it or not, three-fourths of people, adults, are going to have some kind of a complaint, a headache, injury, whatnot. 250 will seek care out of 1,000, But when you get down to university hospitals, only 1 out of those 1,000 ever make it to a university center. And if that's where most of the research done, you can tell right away that their research is not going to help me a whole lot. I'm care for more out in the 250 region. This study was redone then in 2001 by Larry Green and his colleagues, and you can see the numbers aren't too much different. We have a few more boxes on this slide, but you can see that not many get to the medical center. So it remains true that if we don't do our own research out in the primary care world, we're not going to be doing a very good job of caring for our patients. Furthermore, there's a lot of selection in these large randomized trials. Most people are not eligible to participate in large clinical trials. The SHEP trial was one of the best, and even that trial only included 24% of those who were eligible to participate. As opposed to our studies up in our little network in Upper Michigan, although granted these weren't big randomized trials, some of them were at least moderately invasive, and our participation rates were enormous. I mean, we captured just about every patient who might have been eligible to be studied, and that tends to be true of practice-based research networks. So it makes the results much more generalizable. And for the statisticians in the crowd, here's my statistical argument. If you look at the typical flare of confidence intervals around estimates, we know that they flare out as the data thins out. And consider that if a randomized trial is done across the middle of the diagram there, the confidence intervals are much narrower. And if our patients are more unlike the patients enrolled in trials, chances are that our confidence in treatment recommendations are going to be much less. So this again is a reason why generalizability is such a huge issue unless we study most of the patients with the illnesses. And then finally, the knowledge needs in primary care and the approach to primary care really has to be different. And if you haven't read this allegory published in 1989 in BMJ, you really should. The Gatekeeper and the Wizard. Go back and look it up. It's such a terrific exposition of why primary care doctors have to practice with sensitivity and specialists have to practice with specificity in mind. They're sort of the court of last resort. They have to make the right diagnosis, whereas in primary care we can temporize because most of the patients don't have bad stuff. We have to be able to pick out the bad stuff. That's the sensitivity issue. But we don't have to be specific with a lot of diagnoses. So my approach to dizziness is very different than an ENT physician. My approach to headache is very different in many ways than a headache specialist. And that's right, because we deal with different patients. And that's the reason that findings from specialist studies and recommendations from specialists often are wrong. They provide us with the wrong advice because they're not talking about my patients, they're talking about their patients. And so unless we have these primary care networks that study their own patients, we're going to be doing a lot of damage to our patients. The worst example I have is, no, I won't go into that. Let's continue through the slide. I could talk a long time about these issues. Well, here's some examples of what some PBRNs have done, okay, just as short examples. And these are all sort of classic examples, so they're old examples. They're recent examples of interesting work as well. I think this one was most instructive. At the time, CT scans were recommended for new headaches. The family docs sitting around the Aspen table said, well, we don't do that. And so they studied it. So they enrolled about 1,300 patients with new onset headache in a descriptive study, and they found that only 2% of their patients were getting CT scans, even though the NIH consensus panel said they should all have a CT scan. And well, was that good or bad? Were they missing stuff? They did a follow-up study and found out, no, they actually weren't missing stuff, that these patients who had serious pathology had more than just headache. So that study determined that the routine use of CT for adults was not necessary. So this was a group of family docs in practice sitting around the tables questioning conventional wisdom. And actually subsequent to that, there have been a number of trials done by the neurologists who say, yeah, I guess you guys are right. And so now we have a red flags approach to headache. Spontaneous abortion, the same way. Family docs sitting around the table talking about how they manage spontaneous abortion. The recommendation at the time, the textbook said D&C for everybody. Well, these docs said, well, you know, I don't really do that. Is that good or bad? And so they did a case series, descriptive study, 171 spontaneous abortions, and 40% of the women did not get D&Cs. Well, is that good or bad? You know, are they practicing bad medicine? In addition, if everybody did, it would have added a lot of healthcare costs. So the OBGYNs read the study and they started doing their own studies, and they figured out that expectant management is acceptable. And so now I hope medical students and residents these days are taught expectant management, which is cheaper, less invasive, and effective. And why do we do that? Because a bunch of family docs sat around the table and said, I'm not sure that's right. This was just an interesting descriptive study. We think of night sweats and women in menopause, but it turns out that's not the case. Turns out a lot of people have night sweats, and this still remains a very under-investigated phenomenon. We found in our practices up in the Upper Peninsula of Michigan a very high prevalence of obesity, much higher than the statistics showed at that time. In fact, we had about close, as you can see, close to twice the prevalence of obesity in the patients who presented for care in our practices. A lot of patients. And we repeated the study in the PBRN, in fact, later on and found the same thing. And I still don't think we have a good explanation about why obese patients are more likely to land in the doctor's office compared to non-obese patients. I mean, we can all have theories about why that's true, but nobody has really, I think, totally figured that out. Maybe obese patients are less healthy, maybe they have more health care needs, or maybe they perceive their health as worse. I don't know. The backup antibiotic prescription study was another interesting one. Patients want an antibiotic for their URI. You just can't say no, but maybe you can say maybe and just give them a prescription and tell them not to fill it. And that's what this was all about. And turned out that only 50% of those who got the prescription actually went to the pharmacy and filled it. And again, subsequent trials along this line have shown that it's a reasonable approach when you just can't talk the patient out of an antibiotic. It at least cuts down the use of unnecessary antibiotics by 50%. This is a fascinating study that was done in the PROS network, the National Pediatrics Research Network, in which they were studying fever in young children. And again, the conventional wisdom was a lot of workup, and the AP had developed guidelines. And so the PROS doctors also scratch their heads and say, well, I don't always do that. And so they studied, 3,066 infants. And what they discovered was that there was a low incidence of bacteremia, and they discovered that there was a very low rate of meningitis in those who otherwise looked well. But I think more importantly, the practitioners only used the national guidelines in less than half of cases. And the ones that didn't follow the guidelines did just as well as those who did. And they found out that sort of conventional clinical judgment, again, was just as good and was less costly than following the guidelines. Very interesting study. Not being a pediatrician, I'm not sure how this changed management since that time, but this was a really important study that was published in JAMA almost 10 years ago. But these are just examples of studies that emerge in these PBRNs that have changed practice or uncovered interesting phenomenon. I think these tell us that research is a two-way street. Okay, you've got to translate research into practice and vice versa. Clearly the focus is at the sharp end of practice, the microcosm of practice, using real data on real patients. And frequently these PBRNs tend to want to challenge conventional wisdom. Conventional wisdom is often developed by specialists who tell us what to do. And these are doctors saying, well, I'm not totally sure that's right. Let's figure out if it's right or not. If you've ever been to one of these meetings, these are very exciting meetings when you bring these doctors together with researchers and sit them down together. You really get a lot of innovative ideas coming out. And it really starts to fill this void of no research in primary care. We've got good hospital-based research and good population health research, but not much in practice, and obviously this bridges over into community-based participatory research of a certain sort. And practice improvement, of course, is a real focus. Well, these are collaborations which some of these networks have developed, so I wanted to quickly go through two more things. One is the structure of what some of these networks look like, and finally, an illustration of the Oklahoma Research Network and how they operate, which might serve as a bit of a template for you. I think the stable structure for a PBRN looks like this. It's triangular, it has a central office, it has the medical offices, the doctors in the community, and it has researchers who are interested in it. If we break down each of those triangles, the central office needs to have a visionary leader, somebody who coordinates things, and an administrator. The practice has to similarly have a visionary practice leader, a site coordinator of some sort, and the practice owner has to buy into this. If the owner of the practice doesn't, you just can't get anything done. And in the research side, it's much the same. I think there are three parts to that triangle. So if you put it together, at least to me, I call this the Hickner PBRN model. And when I go around the country, these are the elements that I see exist in successful networks. Now, the collaborative improvement approach, I think, is exemplified by the Oklahoma Resource and Research Network. So it was not set up strictly as a practice-based research network, but it was set up as a resource primarily for rural physicians in Oklahoma. They decided to set it up as a not-for-profit, although tightly linked, obviously, to the university. And here's their mission: to improve the quality of primary care services available to Oklahomans through resource development, exchange, research quality improvement, and training. So a very large agenda, and this is a very fancy diagram that I'll break down and explain bit by bit. 56 practices, 36 were private, 10 clinics, 7 Native American, 1 FQHC. The centerpiece of their approach is called the Practice Enhancement Assistant. And this is the change agent. This is the master's level person who would go out to the practices, who would be the study coordinator, but also a practice change agent. And each of the P's, as you can see, had a very diverse role, including quality improvement, acting as a research assistant, disseminator of ideas. Think of the extension agent, okay? This is much like the extension agent for research and quality improvement. Each of the P's had 8 practices assigned. Each of those yellow boxes is a practice. And 8 was a magic number because they would be physically in each practice 1 day every 2 weeks, that's 8 days, and 1 day per week they would be home at the university talking to each other and doing things back home. So they were on the road 4 out of 5 days per week. So they were really traveling change agents. And that's the model that Jim hit on, and it seemed to work. So there you can see the P sitting between the central office and the practices. And so that's what the structure looked like if you had 6 Ps and 6 times 4, 48 practices with the office in the center. And they had the central office, the academic medical center sitting up on top, which provided a lot of the resource and brain power, obviously, in the researchers. And then this is the affiliation between the research network and OHSU with benefits in both directions. And then finally, because of data needs, this is probably key. You see that they eventually figured out they needed more skill in data extraction, collection, so they actually spun off that function, which is something that you could do here. I know there's a statewide health information network, so that bottom box, I think, is just critical. the data management box, and you've got to work that out. That's a very specialized function, and these days where aggregation of clinical data is possible but very complicated, that's sort of a specialized part of the whole enterprise. And look at this. I mean, they really reached out, just as you all are talking about doing. They reached out to their QIO, that's their QIO at the top, the Foundation for Medical Quality. They had projects funded by the QIO. Also the State Health Department, Healthcare Authority, State Medical Association, the Academy of Family Physicians. So they really networked and took advantage of these other resources and organizations to support themselves. And they identified this best practices method as a good way for quality improvement. That is, find the stellar practices that are doing it well, and then spread the news, spread the word as a method of quality improvement. And that's a whole separate talk. It's a way to affect change much more quickly than through randomized trials. Of course, PBRNs are not the answer to everything. They are difficult laboratories to work in. There are issues of data quality, accuracy, completeness. You're not sure that they're truly representative. There certainly is selection bias that can be introduced in studies in PBRNs. The multiple IRB issue can be a problem. If you can overcome that, that's a real service. And it's always difficult, of course, aggregating data across different electronic medical records, but it's technically it can be done. It's more of the human factors that are the issues and barriers. And PBRNs have a hard time with sustainability because they tend to have very thin infrastructures. So it really depends upon the value that academic medical centers, NIH, CMS, and the rest find in these structures. So you obviously have to deliver value to convince the funders to want to support this endeavor. And that's the end of my formal presentation to lead into the discussion of what's the structure and function of the West Virginia PBRN going to be, and those are the discussions we've been having this morning. So, in the words of Bob Dylan, you better start PBRNing or you're going to sink like a stone, for the times they are a-changin'. Thank you. Well, I talked a little longer than I intended. I probably covered too much content, but I figured I had one shot at it with this audience, and we still do have time, perhaps 10 minutes for questions.
It's not so much a question yet, but I really like the notion of bridging research and quality improvement, and treating quality improvement as a form of research. And in terms of getting started with our primary care departments around the state, I think that that's something that they can really latch on to. I think it makes the research process very applicable to what they do day-to-day application care.
Because this is being recorded and because there's some folks out in the hinterland, I'll just repeat the comment, Adam, and that is that Adam felt that there is good potential in taking a quality improvement approach because the practitioners are more likely to be interested in participating if they're getting some value out of it. Arnie?
I have a question about the Oklahoma model, where you have the PBRNs, et cetera, traveling so much, 8 days out of 2 weeks.
Mm-hmm.
What is the possibility of utilizing telehealth, telemedicine applications, things that let you do the internet, video conferencing, those kinds of things? I appreciate your point on face-to-face, on-site discussion, but that's an awful lot of travel. I wonder if we can develop a model that can do this over distance using some of the communication tools we have.
I think you should try that. The comment is, what about using telehealth so that the practice facilitators, change agents, whatever we call them, don't have to be on the road quite so much. They still have to have some appearance, I think, in practices, but I think that would be a great model to try to develop and see how it works.
Just to add to that, I think that's very doable. If there's already good rapport and relationship with the partner, I think it's easier to do things remotely. Maybe just getting started for our companion. We do a
the comment is that, yes, this could be a promising approach that we could do here in West Virginia. However, there needs to be some face-to-face contact to build rapport and trust. Yes?
Thank you, John. This was terrific. Earlier this morning, you spoke with some of us about the possibility of the intersection between public health and medicine, with that intersection being primary care. And I wonder if you could talk a little bit about that, because I think that's the kind of message that folks need to hear. There's a niche there. You could describe this niche about focusing on primary care and why that's important.
Well, this is in my opinion, this is the largest opportunity for the West Virginia practice-based network and CTSA, CTI plan in general. And that is, if West Virginia could demonstrate to the rest of the country that it is possible to unite public health and primary care the way it's done naturally, say in the UK, that would be an absolutely enormous contribution. Then the question is, how do you design programs that would engage both the practitioners in the practices, the physicians, the clinical pharmacists, the nurse practitioners, the physician assistants? How do you engage them and keep them interested, and at the same time include a public health approach? And I think it's possible. We talked earlier about the San Diego model for approaching childhood and adolescent obesity. So there are some people around the country who are trying that kind of an approach, and I think that's obviously a growing approach. The High Plains Network and their attempts to try to get patients intimately involved with the network. But I would say nobody has cracked that on a large basis, and that would be terrific if you all can try that and have some success. And there's a class coming in, so we have to vacate. Thank you.
But thank you, John. Appreciate everyone's interest, and see you next month at CTSI Symposium.